please.
Thank you, Dr. Jasjit, and it's really heartening to see the halls full, especially for Anand and for the two Bhattacharyas here. Well, I'll try to cover up the two other trials. Dr. Arpandev covered Surmount 1 and Surmount 4, and he really discussed with us why Surmount name was given and why weight reduction with medications now is almost as efficacious as bariatric surgery. So I'll discuss Surmount 2 and Surmount 3. This is again my disclaimer, similar to the other speakers. This program is sponsored by, and all the speakers presenting here are on behalf of Eli Lilly. And please do not take any photos or videos. Uh, do not post anything on the social media. And I have been contracted by Eli Lilly, Novo Nordisk, AstraZeneca, and many other companies. But this talk is for Eli Lilly and Company Private Limited, but the views will be totally unbiased. We'll be discussing mainly science. Let me, does the pointer work? इसमें से चलेगा ये चलेगा इसमें okay. Okay. So we will be discussing mainly the Surmount 2 trial and Surmount 3 trial. Surmount 2 trial is comparison to placebo in patients with type 2 diabetes who are obese or overweight. Surmount 1 and 4 were in non-diabetes patients. Surmount 2 is in type 2 diabetic patients who are overweight or obese. 72 weeks trial, and it was completed in April 2023. And Surmount 3 was comparing it with placebo after an intensive lifestyle program in obese or overweight non-diabetic people. And again, it was a 72-week trial. If you look at the baseline characteristics, first we'll look at the Surmount 2. You can see the average age or the mean age is 54. Age less than 65, about 773. So that is.
No, carry on.
Yes. Yes, I was going to have a pointer from the. Yeah, thank you so much. So, majority of the patients, 82% of the patients were below age of 65, equal male and female, probably more female here. And the other baseline characteristics were same as far as the Surmount 2 trial, the drug group as well as the placebo group. The trial was comparison of Surmount the tirzepatide once a week for type 2 diabetes patients who were overweight or obese. Okay. Now the study design is very simple. The exclusion criteria and inclusion criteria are standard. Age more than 18, BMI more than 27, diagnosis of type 2 diabetes with HbA1c between 7 and 10 at the time of screening, and stable therapy, and treated with any other agent except DPP4 or GLP-1. This is the inclusion criteria. The exclusion criteria, of course, type 1 diabetes, previous treatment with GLP-1, and any injectable therapy for type 2 diabetes, those were excluded. Now the patients were randomized to either placebo or 10 milligram, gradually up titrated starting from 2.5, then 5, then 7.5, and then 10, 1 monthly up titration. And one group was up titrated up to 15 milligrams. So placebo, 10 milligram and 15 milligram. Placebo means, as Dr. Arpandev told, a blinded pen which nobody knew. But in clinical trials, those who have done GLP-1 trials, everyone knows that this patient is on placebo, this patient is on the actual drug because of the gastrointestinal side effect that the drug produces. Now let us look at the body weight change from baseline to week 72. You can see that with 10 milligram of Monjaro, the weight loss is 12.8%. And with 15 milligram, it is 14.7%. This is much less compared to what you saw in Surmount 1 and Surmount 4. The reason being that the diabetes patients in general lose less weight compared to the non-diabetic for several reasons we'll discuss probably in the discussion part. If you look at the percentage change in the body weight efficacy estimate, which means those patients who actually could achieve the full dose. It is also almost similar, 14 and 18% and 13.4% with 10 milligram and 15 milligram. 10 milligram having less weight loss compared to 15 milligram. Compared to placebo, this is significantly much more weight loss in both the groups, 10 as well as the 15 milligram. The percentage of participants achieving weight loss is much higher compared to the previous therapies which we used. You can see here that more than 5% weight loss was seen in almost about 80% of the participants. More than 10% weight loss was seen in about 60 to 65%, whether the dose was 10 or 15 milligram. More than 15% weight loss in about 39 to 45% of the patients, and more than 20% weight loss in about 20 to 30%. Here the difference between the 10 and 15 is remarkable, and compared to placebo, the weight loss is, as Dr. Arpender told, humongous, enormous weight loss you can see with both 10 and 15 milligram dose. Even in person with diabetes. In person with obesity, you saw much higher weight loss, but for person with diabetes also, you can see a significant weight loss. The participants who achieved weight reduction target at week 72, you can see that in the efficacy estimate, again, more than 5%, almost 80-85%, more than 10%, 60 to 65%, more than 15% weight loss in about 39 to 45%, and more than 20% weight loss, about 21% in the 10 milligram group and 33% in the 15 milligram group. Efficacy estimate almost the same, so I will not discuss that. It is not just the kilogram that you are losing, you are also losing the centimeters. As far as the waist circumference is concerned, with 10 milligram, 10 centimeter waist circumference reduction, with 15 milligram, 13 centimeter waist circumference reduction. Again, less compared to the non-diabetic obese population. With placebo, only 3.3, because these patients were also on aggressive lifestyle measures. So efficacy estimate again 13.8 with 15 milligram, 11.2 centimeter reduction with 10 milligram of tirzepatide. HbA1c, a significant reduction compared to placebo. Placebo subtracted reduction of 2%, 2.08%. In placebo group also you have 0.51, so 1.5% is the treatment difference between the two groups. So both 10 and 15% are equally effective as far as the A1C reduction is concerned. 15 milligram has more efficacy as far as the weight reduction or the waist circumference reduction is concerned. Lipids, interestingly, the triglycerides went down, the non-HDL went down, the HDL went up, LDL went up a little bit, but not significant because the non-HDL is going down. The overall other markers of lipids are going significantly down. In other surmount trials, the LDL has gone down. Only in this diabetes trial, the LDL has gone up a little bit, but it has gone up also in the placebo group. So probably the trial population. So in placebo group, the elevation of LDL is much more significant compared to the tirzepatide group. Blood pressure again, as you saw in the SGLT2 trials, there is hardly 2 or 3 millimeter systolic blood pressure reduction. Here you can see even in diabetes patients, almost 6 to 7.7 millimeter of Hg mercury reduction in the blood pressure. Systolic blood pressure reduction goes down by about 7 millimeter and diastolic by about 2 or 3 millimeter. Now looking at the adverse events, I'll show you this treatment emergent overall adverse events. Understandably, the gastrointestinal side effects will be much more. And that is how the drug works. You can see that the diarrhea in about 20% of people, nausea in 20% of people, COVID-19 because the trials were done during that phase, vomiting, decreased appetite, constipation. The GI side effects dominate both with 10 and 15, understandably more with 15 compared to placebo. But the serious adverse events, if you look at the overview of the adverse events leading to drug discontinuation, very few. 4% in the tirzepatide 10 milligram, 15% in tirzepatide 15 milligram, and 4% in the placebo. So almost comparable to placebo. The drug discontinuation because of the GI side effects was minimal, and this is really interesting and surprising also. Adverse events of the special interest, if you look at, uh, retinopathy is one of the complication which is talked about, but in this trial it was specifically looked into, and there was no increase in the retinopathy complications. Neither there was any increase in the malignancy, pancreatitis, cardiovascular or gallbladder disease, or actually the suicidal ideation was also not increased in spite of good weight loss. So the conclusion of this trial, that is Surmount 2 trial, is that both 10 and 15 milligram demonstrated superior and clinically meaningful body weight as well as HbA1c reduction compared to placebo. Up to 82% of the patients, or rather the participants, achieved more than 57% weight reduction, and up to 30% patients achieved more than 20% weight reduction. Uh, Up to 15.5% participants achieved the exploratory endpoint of more than 25% weight reduction with tirzepatide 15 milligram, and it improved the cardiometabolic risk factors including the waist circumference, BMI, systolic diastolic blood pressure, and lipid levels also, especially the triglyceride and the non-HDL. All doses were well tolerated. The discontinuation rate because of the drug was very minimal, and the findings from the Surmount 2 trial may advance the therapeutic potential of medical treatment options for people with overweight or obesity with type 2 diabetes. So the starting dose should be 2.5 milligram. After 4 weeks, escalate to 5 milligram, and if needed, you can escalate it to 7.5, then 10, and 15 milligram is the maximum dose at present recommended. So what about in people without diabetes or in people with obesity without diabetes? So this is the trial. The Surmount 2 trial is in patients with intensive lifestyle intervention, those patients who already underwent the intensive lifestyle intervention, and then they were offered either tirzepatide or placebo. Double blind, of course, randomized, multi-center, placebo-controlled trial. Here again, the patients were up titrated from 2.5, 5, 7.5, 10, 12.5, and then the option of 10 or 15 milligram, and one group received placebo. Let us look at the weight reduction. 21% weight reduction in the non-diabetic group. You can see Surmount 4 patients are not having diabetes. So 21% weight reduction in tirzepatide group compared to some weight gain in the placebo group, because these patients were already on intensive lifestyle. Over and above that, then they were given tirzepatide, and you can see that you have a significant weight reduction of 21%. Whereas those patients who just continued on the lifestyle and they were given placebo, then they had actually weight gain. So the treatment difference between these two is very, very significant. So the overall mean baseline body weight at the start of the trial, it was about 103 kg here. They lost about 25 kg. So the difference between the two group, the placebo and the tirzepatide group, is very, very significant. If you look at the absolute change in the weight, in the placebo group, there is weight gain. In the 10 milligram group, 21.5 kg weight reduction, and in the 15 milligram, you have after 72 weeks, 29 kg. The change in BMI also very, very significant, 7.7 and 10.4. The proportion of participants achieving weight reduction threshold at 72 weeks, you can see more than 5%, 87% of the people lost weight. More than 10%, 76%, more than 15%, 65%, more than 20% weight loss, 44, and more than 25%, 28% weight loss. There's some difference in the treatment regimen estimate and efficacy. We'll not go into that details. The change in the waist circumference, again compared to the placebo group, so intensive lifestyle followed by placebo plus intensive lifestyle versus intensive lifestyle plus tirzepatide. Again, waist circumference reduction of 14.6 centimeter, almost 6 inches. Here again in the efficacy estimate, slightly more. The blood pressure also went down here in this group about 10 millimeter of mercury, the diastolic by about 6 millimeter mercury, which is again very, very significant. The lipids, you can see here, the LDL also going down in the tirzepatide group. The other things are obviously towards benefit in the tirzepatide group, but LDL also has gone down in the tirzepatide group compared to the placebo group. The adverse events, understandably, most of the adverse events were GI in nature. Serious adverse events were similar between the two groups. So, no increase in the serious adverse events in the tirzepatide group compared to the placebo group. Most of the adverse events are GI. You can see that in the tirzepatide group, much higher compared to the placebo, but the serious adverse events were similar. So, to conclude the Surmount 4 trial, tirzepatide demonstrated superior and clinically meaningful body weight reduction compared to the placebo. From randomization, additional 18.4% weight reduction with the tirzepatide compared to 2.5% gain with the placebo. From start of the trial to the leading intensive lifestyle lead-in period, 24% weight reduction with tirzepatide compared to 4.5% with placebo. Almost about 87.5% participants achieved more than 57% additional weight reduction. This is very important. Intensive lifestyle had already caused some weight reduction, and there was additional 57% weight reduction with that addition of tirzepatide compared to placebo from randomization. 28% of the patients achieved exploratory endpoint of more than 25% additional weight reduction, and the tolerability was excellent. Of course, the GI side effects were much more, which is due to the mechanistic reason. The GI related side effects were very frequent, but requiring dosage discontinuation or serious adverse events were balanced between the placebo and the tirzepatide group. So that's why I'll end here. We have a very good discussion session. Over to you, Dr. Jasprit Wazir, and thank you very much everyone for coming here for Diabetes India, and please enjoy the academic fest here.